Next up, we wanted to share a spotlight video, and it takes us to Kenya, where disruption is access and action. The Empower Initiative by Roche is transforming women's health through community clinics that bring cancer prevention, early diagnosis, and treatment directly to where women live. In partnership with the County First Ladies Association and the Africa Cancer Foundation, a GCCA member, Empower has expanded to 14 clinics across Kenya, training community health workers and women with disabilities to deliver care. This is amazing, guys. Adopted by the Kenya government in July 2025 as a national model for women's cancer care. Empower stands as a blueprint for disruption, where data, dignity, and collaboration drives change. Let's watch the video.
It's a story about access, it's a story about women, and it's a story about leadership.
My grandmother died from cervical cancer, and it wasn't found out until it was too late. So I felt that their health-seeking behavior, and certainly culturally and socially around them, it wasn't something that was easy to discuss because, you know, it revolves around your reproductive health system.
Women generally do not go for screening. The level of awareness is low, and breast cancer and cervical cancer, if detected early, can actually be cured. They can also be prevented if only the women knew what to do.
In Makueni, when the clinic was actually incepted, most of these people used to be terminally ill. Cancer was the number 3 cause of mortality in our facility.
This gives cancer the image of being a death sentence. And personally, I'd like to change this narrative. So about 3 years ago, County First Ladies Association partnered with Roche, Women for Cancer, Africa Cancer Foundation, and International Cancer Institute to plant cancer screening clinics for women around the country. And to date, we have planted 14 dubbed Empower. The purpose of this was to bring screening to the doorstep of the communities.
And that's what drives me. I want to see a situation in this country where getting treatment for cancer is as easy as getting your baby immunized for polio.
If you catch the cancer early, you're able to treat it early. Now, the good thing is right now we have a dedicated unit whereby when women come for their family planning services, they are able to access advice and screening on the same. They're actually taught how to do this at home and what to report.
And we also hope that there'll be a reduction of stigma when they realize that this is a common thing. It's okay to talk about it. This empowers them. They get to understand what to look out for in their body so that when they do go to a hospital to see a doctor, they can discuss these things openly.
Na wakati huu nilikuwa mgonjwa, nilisaidia watu 3. Nikimwambia nenda hospitali waangaliwe, na mtu akisikia chochote kimbia uone daktari.
Initially, there was no cancer clinic in the whole of Taita Taveta County. Now, care is close to home, it's close to family, so that translates to better outcomes. There is no loss to follow up, and that will translate to more cure rates.
Hata mimi inanisaidia sana, na ninashukuru sana. Na kila naweza kusema kwa serikali iendelee hivyo hivi na wahurumie watu wa saratani, sababu kuna mtu ana chochote.
It's so important to invest in women's health. Women are the backbone of society. They are the nurturers. They are the ones who raise the future generation. And if their health is compromised, it compromises the quality of life of the children that they will raise.
5 years from now, I see the Empower Clinic being the focal area in terms of cancer provision in our local settings, providing care that is affordable and accessible to all our patients and also our community.
We at Roche believe that prioritizing women's health uplift families and communities at large. And that is why we are working together with partners, both in the public and private sector, to ensure that we have a healthier future for women in Africa.
So we are happy to share that our next segment is with Jackie Wambua, whose work with Roche Empower Kenya shows how technology can either widen or bridge the data divide. And she turns disruption into design and gives us an insight as to how they did it and what they're doing. So stay tuned, and I hope that you enjoy this as much as I did. Well, good morning, good afternoon, and good evening from where you're tuning from. It is a pleasure to welcome Jackie Wambua, who is the General Manager of Roche Pharma East Africa. Jackie is a leader who drives transformative change, turning personal conviction into action through initiatives like the Empower program, which is redefining cancer care and access and inclusion in communities of low resources. And it is an amazing program that caught our attention and that we are so happy to feature and to talk to Jackie about. Jackie, thank you so much for your time and welcome, welcome, welcome.
Thank you very much, Candace, for the opportunity, and I look forward to our conversation, especially focusing on the East Africa region and what we've done to create patient impact.
Thank you. So I will get started with the question. So I was so as I said, it just blew my mind, this project. And I was like, this is what needs to be featured. Can you tell us how this got started? There's mention about the Colombian inspiration, the peer-to-peer learning with Colombia was a brilliant catalyst, right? And beyond the clinical model, what was the most surprising or non-obvious insight you brought back from Colombia, engaging the community that couldn't learn from a report, that you could have learned from a report?
So I think it was visiting the clinics. And the need for me to go for the peer exchange really came from a collaboration that we already had with the Ministry of Health, then here in Kenya and Sudan. But financing for health for breast cancer treatment, standard of care, was really a challenge. And so the government in Kenya suspended the program because of financing for health. And so the opportunity to go to Colombia was a good opportunity to go and learn because our health systems were a bit similar. There was a bit of learnings there because they were working very well with their government. So I needed to understand what is it they've done. And what I would not have learned from a paper or even a program or even a class was to actually go and visit an Empower clinic. So they actually call them the pink offices. The pink offices were set up for clinical breast examination for women. And because of the stigma of breast cancer in Colombia, about 10 years before that, was because most of the clinicians were men. So the women did not want to go for clinical breast examination because a lot of the clinicians were men. So Roche Colombia and this faith-based organization that was running a number of hospitals came together to run the pink offices. The pink offices now were bringing community health workers who are blind. And the blind would be able to do the clinical breast examination. And I think there's a study that has been shown that a blind person is as good as a mammogram in terms of identifying certain sizes of tumors in the breast. So that was the program. And I think you can read about it. It's called Hands That Save Lives.
Wow, I'm going to look that up. Hands That Saves Lives. I think that's such an amazing program. I hope everyone else took notes too, as well as to write that down and look that up. Hands That Saves Lives. And while you were talking, you brought up such an important point, and that speaks to barriers. And I may skip around a little bit, but we're having a fluid conversation. But that just brought up to me when you shared with me that, because the ladies were concerned that all of the clinicians were men, the important part was the fact that the women didn't feel comfortable, and so they weren't going in. But so that speaks to cultural barriers, personal barriers, right? Because it's not just cultural, it's also personal. If I don't feel comfortable, then I won't go. That was very eye-opening, and it speaks to how important it is to listen to the community, correct?
Yes, and especially with something like cancer, because really, one thing that we know about cancer, the patient doesn't have time. So time is really critical for this patient. So letting the patient come to a room that looks fine and was pink, creating a conducive environment for the woman to speak and have a conversation with a clinician was actually the intention of this partnership. And at that time, they had over 180 clinics in the country.
Wow. You said 180 clinics?
Yes.
Wow. Now, how long had that program been going on then in Colombia?
Almost 10 years by the time that I was going, and that was in 2018, I think. So it had been going on for almost 10 years, and that's why the success really had helped women to navigate and to also come for the clinical breast examination, because they were fine having a woman and also giving purpose for these women who are blind to find something that they can impact, not just the health system, but also impact other women.
It does, but it also speaks to another point. And and I know that's not about, about this conference, right? But it's also speaks to how these women use their, and I'll say different abilities, right? Society calls it disability. I like to call it different abilities, right? But they use their different abilities to help ladies do life-saving care. So that's a whole, I'm just like, oh my God, that just shows the creativity of, if you want to make a difference, if you want to change lives. So it not only changed the lives of potential cancer survivors, it also changed the lives of people who were dealing with different abilities, and give them a purpose, right? Out beyond, right? I don't want to suggest that they didn't have a purpose before, but it gave them another purpose in life to utilize that different ability to save lives. So I'm just like, oh my God, I'm writing it down because I want to find out more more about that. But that speaks to the creativity. If you want to get something done, just think a little deeper, think out of the box, think of like, what are we missing in this? And um, so that being inspired by this program, because I'm even more inspired now. How can how did you get involved, or how did the first ladies, because I wanted to, just speaking about partnerships, right? Like, and I saw that the first ladies group are involved. Can you talk about the involvement? So I want to talk a little bit more about partnerships and how that helps the program.
So having had the experience of the pink offices, it was really important for us to come back to our local situations, look at our local challenges. And in Kenya, breast and cervical cancer are the leading cancers for women. So one of the things that we did before we could actually start the partnership and collaboration was to have several meetings with different stakeholders to understand, okay, this is what we've learned. We've got this experience that we've gone to Colombia and seen. Where Colombia was when they started the pink offices and where Kenya ecosystem is in the same place. What can we do really to ensure that patients, women, are showing up for screening? Because that's where from the preventive perspective, we don't really want to talk about treatment. And so after a couple of engagements is where we learned about the County First Ladies Association, which was the governor's wives. And in our conversation then with the First Ladies, they felt that we cannot have pink offices, we need to have clinics for breast and cervical cancer. Because then so that now we're not just talking about a disease, we're talking about a woman. Because when she shows up, we cannot just do a clinical breast examination. Let's have a cervical checkup. Can we also look at her cervix? Can we also do just a simple blood pressure check and have a glucose monitoring check in the same clinic, so that we are talking to a holistic issue of women. We're not just looking at breast cancer and cervical cancer. This woman is coming from the village, does not have time. The other thing that we looked at is, where do we have this clinic set up? And we thought that it needs to be integrated in the primary healthcare system. Reason being, our primary healthcare system has really done well and has really transformed over the years. So like I told you earlier, Candace, that we should not reinvent the wheel. We need to go and see what is already working. And one thing that we identified, the primary healthcare, was where we needed to go, so that we are not setting parallel programs, but within the setup of the community, rather than taking it to the cities. At that time, we only had about 5 oncology centers in the country, and screening was done by mass screening. So a program would come, set up at a market, do a campaign, and then leave. So this clinic was going to be set up where a woman can come anytime. And a lot of the clinics that we have were set up in where the highest number of women find in the hospital. Then COVID happened. So when COVID happened, we had only had 2 clinics in 2020, but we didn't stop there. By the time the lockdown and everything was back to a new normal, that was 2021, 12 of the clinics that we had been opened during the pandemic. And that clearly shows the need, because we were talking about integration of breast and cervical cancer to the primary healthcare setup. We were going to the community, so working together with community health workers, and we were also able to train about 100 blind and deaf community health workers. Now, why did we bring in the deaf women? Because the deaf can see the cervix, so they don't need, so we have the blind doing the clinical breast examination, and the deaf women could look at the cervix and be able to see the precancerous lesions and refer this patient for any treatment that's required, if at all there are lesions that are non-cancerous. So,
Okay. Wow, can I just ask a question there? That is
yes.
that is that is amazing. So can you just elaborate just a little bit more on the blind women working with the cervix? Just want to give a little bit of a picture for the audience, because if they're visual like me, it's like, wait a minute, how does that work? Like, that, I mean, I think is amazing. So you don't have to go deep. I just like, how did that work? How did that get started?
So remember, Empower is a partnership of different partners who came together. So we had the County First Ladies Association, who actually were the ones who are opening the doors for us in the community, because they're the governor's wives. And in the local community, they're the women who are recognized. We are not recognized by the local community. So if they said, come for screening, the community would believe them. And then we also had the patient advocacy groups. We had 2 patient advocacy groups, Africa Cancer Foundation and Women for Cancer, to help us with navigation and providing patient information on breast and cervical cancer. We also had International Cancer Institute that was also helping us deal with the clinical aspects of the Empower clinics, because some of them did transition. Actually, today we have 20 clinics. Half of them transitioned to cancer centers, where patients could start cancer treatments. So who would train those clinicians and the nurses was International Cancer Institute. And then we had Roche, that was the private sector, who was helping also to understand the disease. We had the HPV DNA testing from our side, and also understanding the treatment for breast cancer. Now, we brought in Amref, which is an African NGO that helped us convert the modules for community health workers training for blind and deaf. So Amref took the modules and trained these blind and deaf community health workers because the curriculum did not exist for the special needs of these women.
Wow. Wow.
So the deaf women were taught how to investigate the cervix. How does a normal cervix looks like? How does a cervix with lesions look like? And what happens when you have a woman with lesions? They do not provide the treatment, but you have a nurse who is able to provide any treatment, especially for the precancerous lesions. So that's what the
Wow. I mean, just wow. It's I in listening to the video since you brought up Amref, one of the speakers in the video described it as the fortunate accident. One of the most innovative aspects of Empower is the training of community health workers with disabilities. And the transcript says that it was a fortunate accident. I mean, that's such a statement. It's like, wow, yes, it's a fortunate accident, but it seems to me that it's much more than that. It's an empowerment. All right. So that's why I was like, oh my gosh, since you spoke, since you brought up Amref, I was like, that, there's a statement about, about that, what they did with the training. Also, as we know, and as has been stated several times in the video, women are the backbone of society. One of the speakers said that if the woman is not available or not healthy, the children don't get fed, the husbands are not taken care of, the homes are not taken care of. That was so profound because we are, right? We are, the backbone of society. So in talking about that, we sometimes know that as women, everyone else comes before us and taking care of, the household. And so we don't always take care of ourselves. And with that, I also read that there's no word for cancer. So if a woman who is the backbone of society and the backbone of her family and does not have a word to explain, how does she seek care? And how does this program help that?
In our local languages, there is no word for cancer. So whether it's colon cancer, whether it's prostate cancer, or it's breast cancer, or cervical cancer, there is no name cancer. So, and until recently, even with our second national language is Kiswahili, recently is when we had a name for cancer. So when you have something that's suspicious or you actually have cancer, so they just say you're sick. And that also complicates the navigation in the healthcare system. Because where are you going? Who are you going to see? What specialists do you need? So to actually bring first to explain what cancer is, what are the symptoms, and to also remove the stigma associated with it, that cancer leads to death. And that is brought up by the complexity in our healthcare systems, especially in the primary, in the public and primary health sector, because really the disease is not understood. In a country of about 50 million people, we probably have about 40 oncologists. So you see that dynamics of even to get the treatment really is a process. But one thing we did with Empower was to really ask ourselves, what can we learn from other diseases like tuberculosis and HIV management? Because they have been able to have a proper navigation and a sensitization, even at the lowest level of the healthcare system. How do we navigate these women or men from the community to the health system and the proper health system? Because you can find yourself in a health system, but it cannot be treated. So that whole navigation program was really critical. Remember, we started with a women's need, and a number of these clinics transformed to cancer centers. So they are not cancer centers for women. There are cancer centers for women, for men, and also for children. So it became now bringing a women's issue that became now a community issue and a family issue that has really transformed how we are looking at cancer as a whole. 2 of our clinics, I can tell you today, also have endoscopies and also are able to do screening for colon cancers, because it's something, depending on the community that we are working in and the prevalence of which cancer in certain communities, the clinics would evolve to treat those cancers and to manage those cancers. Clinics, men would follow the women, out of curiosity. So we also educated the men on prostate cancer. And also for the women, we also talked about HPV vaccination, because if they have daughters, it was critical that if the children are being provided vaccination in school, we educate the parents on the importance of completing the treatment of the 2 vaccines for these girls, because at the end of the day, we would like to also eradicate cervical cancer in Africa. So that conversation became a holistic conversation, both for the man, the woman, and the daughters.
I so loved it because, what started, as you said, what started off as something for women wind up expanding into something that was a one-stop health shop for everyone. And so I can only imagine, though, that since this is something new, did you have to deal with any type of skepticism from the community, about this? Like, I'm sure, there had to have been some like, what, I don't know about this. Can you talk briefly on what, if you had to deal with any type of skepticism and how you all were able to overcome that? Because I'm sure people, watching were like, okay, great, but in our community, people don't like talking about this, and this. And so I'm sure, if there's any type of advice or, examples you can share, that would be helpful.
Definitely, we had a lot of skepticism. And first of all, if you realize, we're looking at the basic. We wanted to really understand the patient journey. So we're looking at the first step. Where's the first point of contact for this woman or this man? So it was screening, creating awareness. And then if at all there's need, we talk about diagnosis. And so if you realize, when we talk about the initial partners, the government is not there. It is because health is devolved. The county governments were the governments that we were working with. So one of the skepticism also was to find space. Everybody said there was no space. So we did not reinvent the wheel. And because our national governments believe in brick and mortar, our Empower clinics were not built afresh. We found space within the hospital. We looked for a room within the hospital. So the first skepticism was, it was not possible. The fact that we don't have enough nurses to help us work with this new thing that we are bringing up as a partnership. And so we're able to have that conversation with the county governments to have allocation of a nurse. And that's why we integrated. We went to a system that already exists. Of course, the skepticism also there in the health system, I'll give you the 2 skepticism from the health system and the community, was that this nurse is going to be overloaded with work because already she's doing antenatal, maternal health, HIV clinic. So whichever clinic we placed, our Empower clinic, there was always this too much work. Secondly, we provided some technology of maybe a computer so that we can try to digitize that data. Our work was, the work that the nurses used to do was very manual. So providing them with even a desktop was a challenge, because then the nurse would say, the government requires a manual system with a big book that is manually filled. And you're coming to tell me to put this data, all this information on a computer that the government does not recognize. How do we integrate this and remove the manual system? So from a health system perspective, that part of actually having the clinic and then navigating this patient within the health system, where do they move? If they need maybe further diagnosis, where do they do their mammogram? Where do they do their immunohistochemistry? Where do they do their chemotherapy? Having that understanding of the whole healthcare system, we had to sit with the teams, the hospital teams, and we had very good advocates within the health system to say, this is the way it works, so that each and every clinic understands their path, which could be very different from one place to the other. Now, for the community, it was even tougher because remember, whatever disease this cancer was, and whatever, it was just by description, it meant death. So then telling people to go and get screened and they cannot get medication, the women would rather stay in the community and die. Some would rather go to, like you heard from the other speakers, is that panel speakers that they go to traditional doctors to get traditional herbs and not go to the hospital. Now, the myth, especially for cervical cancer screening, because it's invasive, was that we are going to make these women infertile. So most of the communities where the men came was to confirm that we are not doing that. So coming from there, how do we change the community? How do the communities believe that this is important, including vaccination? Because there's a lot of things going with the community that we are vaccinating our girls so that they are infertile and then they can never be able to bring up families in future. So removing all those myths, educating the community health workers who would then go and have these conversations in the community. The women who come to the clinics would also be educated, and any question to be answered, even by the men who would, the husbands who would come to check if we are destroying the fertility of their women, or we are removing something, because they would say we are removing something when you investigate the cervix, there's something we are removing. So all that community we needed a lot of education, a lot of awareness, and also bringing patient stories and hopeful patient stories. So our patient advocacy groups really brought up, went and looked for patients who had been treated, especially in the public sector, and would bring the success stories back home. Because people felt that if you have to get treated and get healed, you have to go abroad. So people must come and do a fundraising for you to go. So we looked, the two patient advocacy groups went out and looked for patients who had actually been treated in the country and are alive today. And those were the stories that would go and say, look, I had breast cancer, I had cervical cancer, I had prostate cancer, or whatever cancer, whether it's a colon cancer, but I'm alive today, and yet I was treated in the public sector.
And that is so important, especially when there is concerns and a lack of trust, and stories of hope are always important. It is always helpful to see a face that looks like yours, that is surviving and thriving, especially in an atmosphere where, as you said, in some areas, cancer means death. And we want to change that narrative. And that is so, that's so important. That's such an important thing for the audience to hear. And the other piece that I appreciate you sharing, for those that are paying attention, don't reinvent the wheel. Using existing structures to help move the needle, even in the face of opposition from, government and, and other partnerships that, potentially don't see the vision, right? It's like, hey, we have these here, we can utilize that. And digitizing data, using, with the assistance of like, okay, we need this, and having the nurses chime in on what's needed to do this work was very important. And so I do have a final question. And so you have shared about every aspect, everyone else, what's happening. I want to ask this question, this program demonstrates a profound shift in how we think about healthcare delivery, and for every other leaders that are watching and watching this, what's the why for you? Because it's so easy to do this work and see everything and sometimes get burnt out and not find the motivation to keep going. But what's the why for you?
Yes, thank you for that question. And it's a very good question. Maybe a question that I've asked myself quite a number of times. First of all, I am a woman, and you hear that breast and cervical cancer are our two two leading cancers for women in this region of East Africa. Secondly, I'm also a mother of two girls. What kind of a health system would I like them to find as they grow up? It's a health system that works for women, that works for families. I lost my mother to breast cancer. So I have been a caregiver for 12 years. I navigated the health system, did everything possible. As you can imagine, in all the things that you were discussing, I know that journey. I know the journey of giving up. I know the journey of consulting. I know the journey of fundraising. And also know the journey where it comes to a place where you say, you have to let the person go. So when I speak, I'm also speaking from experience because I have been there as a caregiver. And I know what it is to lose somebody that you love when all is said and done, when you've tried everything that you can. So if we can save just one woman, one man, one child, we've saved a life. And somebody who means everything to somebody in a family. So for me, that's what drives me. I ask myself that what would I have done different if I was capable to keep my mother alive? And probably what we're already doing. So for me, it's a personal commitment. It's a personal journey. And most of all, we want to change the future for our patients. Our patients deserve dignity. And Empower is about dignity. A patient does not have to travel 400 kilometers to get treated. They should get the treatment closer to home where they have the emotional support system. So really, if we can give one thing back to society as a member of Roche or as a woman, is to give our patients dignity.
That is amazing. And it just gave me chills because that's exactly what I felt when I found, out about Empower. And I shared, like, we have got to find out about this program because it does. And thank you so much for sharing your personal why about your mom. I think that you're talking about it actually shows that that personal journey that you shared with your mom with breast cancer, and I am so honored that you shared that with us. And I want to thank you for such an amazing conversation, talking about not only just Empower, but all of the many patients that you have helped and that you will help. And thank you for bringing dignity to this amazing work that you're doing. You've defined what's what's possible by showing that the best solutions are often born from empathy and inclusion, because by including the men and children in your work, you are now helping the whole family. And so we're leaving this conversation, and I hope that everyone else is leaving this conversation inspired and hopeful for the future of healthcare in East Africa and abroad, because it just showed that you took one program that you found out about in Colombia and you retrofitted it with modifications and changes to fit Africa. And so I hope that everyone else is inspired. And I want to thank you so much for your incredible work and sharing with us today.
Thank you, Candace, and I look forward to more conversations in the future.
Yes.
Thank you.
Thank you. And thank you all for tuning in. And we can't wait for our next program.
Wow. Are you inspired yet? Have you been motivated by any of the information that our speakers have shared today and their personal whys? I just want to thank Jackie for her personal why in reminding us that disruption doesn't always mean standing or starting from scratch, but by adopting a model from Colombia and empowering blind and deaf women as trained health workers. My goodness, that is the disruption by design. Okay, so it's poll time. So Let's go. Let's see what we have here. What are the most significant technological barriers to data collection in your area? And really, we're learning a lot about the challenges globally that people are having, whether or not it's unreliable internet connectivity, lack of computers and tablets, lack of staff and community health workers, or incompatibility of record keeping systems. So would love to get your input and see where we stand with this, because this information all helps us help you and helps the global collective. So it looks like we're about even Stevens around here. So we're doing pretty good with some great information. So either it's incompatible record keeping, which is not surprising because we have the same issue here in the US. Lack of staff and health workers, common as well. So we're on point as a collective. We're all dealing with the same thing. So thank you so much.